Hello, my name is Hugo Aerts, and I'm the director of the AIM program, the AI in Medicine program at Mass General Brigham and Harvard Medical School. So in this talk, I want to discuss AI applications in cancer imaging. So these are my disclosures. All right. So first I want to go into why artificial intelligence. Why is this important and how can we use this in medicine? Then I want to talk about AI-based biomarkers in oncology. So why is this important, and specific in cancer? And at the end, I will give you some examples of application areas in cancer imaging, just to give you a flavor of the studies that are currently performed. So what you can see here is an illustration of performance of humans and AI over time. And what you can see now is that, in current state, due to breakthroughs in artificial intelligence, we can see really that AI starts to match and even in some instances exceed human performance for very specific tasks, including lip reading, driving vehicles, playing Go, classifying skin cancer. So AI is really almost to the level or even over the level of humans for these tasks. And in the future, what we will expect is that AI even goes further, where it's able to automate very complex tasks like writing bestsellers or performing surgeries. And of course, also, we expect that humans can learn from AI and also that their performance and in combination is better than either alone. But what is really interesting is this Gartner hype cycle. And it's really amazing to see how AI follows this cycle. So about a decade ago, there was deep learning was established, which is this, say, now not new, but then new deep learning technique. And this was really a technological trigger, right? So deep learning was outperforming all of the previous technologies for in competitions and such. So that was a trigger. And then over time, you saw this enormous amount of inflated expectations, right? So AI was all that was talked about, especially in medicine. An enormous amount of research studies were initiated, a large amount of startups as well, and all said more or less the same thing: is that AI will solve all problems in medicine. But now we're over this peak, and we go slowly going down, where we see that startups are starting to fail. That do not live up to the promises. A lot of these startups and research studies find that medicine is not a very easy field to transform. Some are even talking about AI winter, where you can hear negative stories that deep learning will not give us, talking robots or general intelligence. So AI is really not living up to our expectations. But what is really important is the main point I want to make here is that after this winter, we'll reach this plateau of productivity, right? And the power of AI and deep learning is real. We can do things today that we could not do a decade ago. We can automate very, very complex tasks. And it is expected, especially in imaging-based professions and in medicine like radiology or pathology, that over the next decade, we'll see very, very major breakthroughs in these fields by AI. All right, so if you want to look a little bit more in detail into cancer, so this is an illustration of the cancer care pathway. So we can see all the different steps from prevention all the way up to follow-up assessment. And what we now see is, and what we expect is that very specific narrow applications will be developed to solve a single or multiple of these touch points along the patient pathway. So think about, we use a neural network, so a CNN, so a convolutional neural network, a deep learning method, together with radiological imaging to better detect lung cancer and screening CTs. But also you can think about, using graph models and cancer genome applications and cancer staging. So this is a little bit what we expect. That's very specific data and methods will be joined together to deliver solutions that address a single touch point or multiple touch point in such a cancer pathway. And another way to visualize this is here this oncology data stream, where you can see that over time from a cancer patient, more and more data is being collected and that this stream becomes wider, right? So for a specific patient that is in one of these stages in the stream, a lot of data is available, which is great in a lot of ways, because we have all of that data that we can learn from, and we can use this to optimize decision making, but also to learn applications that could potentially help for future patients. But also, it illustrates a little bit the overflow of information that can happen in the clinic. There's so much data being generated that we cannot analyze all of that without the use of automated methods or AI methods. So, and again, also here's illustrated how specific solutions in each of these different stages, where AI can help a treating physician and the patient to optimize care. But what is also very important is that these AI models bridge the AI translational gap, as we like to call it. So really go from model development and proof of principle studies to really having clinical impact. So in this, we think that there's three main points that are very important. That is validity, usability, and utility. Where in validity, we want to say, are these models valid? Do they work? Do they work internally, externally? Do we need to prospectively evaluate them in randomized controlled trials or not, for example? So these are very important aspects that need to be investigated in validity. But also, we need to look at usability, right? How easy is it to use them? Are they efficient? Are human operators satisfied by them? All these very important aspects also need to be addressed before we can even think about clinical impact. But also utility, right? So what are we trying to do? What are the clinical end goals? Do we try to predict outcomes? Do we try to predict quality of life changes? How does this change our decision making? So that's also something very, very important. And what we have seen is that a lot of models that are published demonstrate very nice proof of principles, but a lot of them do not bridge this AI translational gap. So, and therefore the clinical impact is limited. And we hope that over the next decade, a lot of research will be focused on moving these tools and these methods really into the clinic, and more rigorously investigating these aspects of validity, usability, and utility. So next, I want to give you some example studies about different applications of AI methods in cancer imaging. So this is a study I'd like to show you that we published about 2 years ago, where we looked at, can we quantify the biological age of a patient, of a person, of an individual on X-rays, right? So even for healthy individuals that have no symptoms and no radiological findings, we know that people age in different rates. So what I want to do is we want to develop a deep learning method that is able to quantify your, say, biological chest age automatically based on a chest radiograph. And it's specifically, of course, deep learning can be used to extract this information automatically. And one of the reasons we chose for chest radiograph is that it is the most commonly used diagnostic imaging test in medicine, and if we would have such a model, it would be easily to implement in clinical care. So again, our aim was to develop a deep learning model to predict long-term mortality from chest radiographs. For data, we used over 50,000 individuals that were included in the PLCO trial. As well as for validation, we also had a data set of over almost 5,500 individuals that were included into the National Lung Screening Trial. And we used a relatively simple deep learning, the V4, Inception V4 architecture, together with, or only using the chest radiograph to predict the survival of these individuals. And if you look at the results, we could nicely stratify the patients into different risk groups with a very high stratification power, only based on this input, on this image as input, this radiograph. And also, once we validated this, we found a very similar stratification power in the individuals included into the NLST. So this really says that there's information about our aging that is captured in healthy individuals in a chest radiograph. But you might wonder, what do we do with this information, all right? So what we did next is a study that we published last year in Annals of Internal Medicine, where we say, can we use such a system to automatically identify individuals that have potentially a benefit from lung cancer screening. So can we identify for, based on an X-ray only, that is taken often for other purposes, where we do not find any lung nodules, can we then identify, this patient will likely develop lung cancer in the far future, right? So simply using that as an automated method. So the CNN model was developed in over 40,000 individuals included in the PLCO. As input, we used very commonly available inputs inputs that are available in an EMR system, like age, sex, current smoking status, for example. And as output, we try to predict who developed 12 years of within the next 12 years lung cancer. All right. We use a very similar architecture compared to the last study for developing the model. And then if you look in our independent held out testing data sets, we found that our model was actually more accurate than the Medicare lung cancer screening criteria, much more significant, where we could really identify these individuals that have a high risk of developing lung cancer. And that potentially would also have a benefit for being included into low-dose CT lung cancer screening programs. And if we would do so, we would miss or detect 31% more lung cancers using a similar screening population size. So this is an example how we could use such a biological age on an X-ray to say, okay, these patients are high risk, and we can then screen them more for lung cancer, for example.
So similar to this, we wanted to see if we can use AI to predict cardiovascular risks from CT scans. And this is work we recently published in Nature Communications. So we decided to look at coronary artery calcification, also called CAC, which is the best known predictor for cardiovascular events, and which can be visualized and quantified easily on a CT scan. Also, the amount of coronary calcium that is visible on these scans can guide primary prevention therapies. So we know what to do with these quantifications. And what is very interesting is that although it's visible on almost every chest CT, it requires a lot of expertise and special equipment to extract it. So an automated method could have an enormous clinical impact because it could perform this measurement completely automatically at low cost. So we decided to build a deep learning system to automatically predict cardiovascular disease. So we developed a platform by several deep learning architectures that were applied to this. So first, we localized the heart roughly in the image. So where's the heart localized within the CT scan. Then we performed a very detailed voxel by voxel segmentation of the heart boundaries on every slice. Then we looked at the coronary arteries and segmented the calcium if it was present or not. And then we calculated the coronary artery calcium score, which is also known as the Agatston score. So this was a fully end-to-end automated system that can analyze a CT scan under 2 seconds on a cluster. And what is really interesting here is that this allows then for the identification of high-risk individuals in both organized and opportunistic screening settings, right? So you can easily apply this algorithm fully automatically to CT scans for low-dose lung cancer screening, for example, but also in hospital ambient settings where you have such a system running in the background, just checking every chest CT scan that comes through a hospital. All right, so to develop this deep learning model, we had access to high quality data from the Framingham Heart Study. Over 1,600 patients were used for training and tuning of the model, where we had high quality cardiac CT scans as well as expert reader segmentations available. So then we trained all of these steps that I explained before, from localization segmentation, calcium segmentation, heart segmentation, calcium segmentation, as well as predicting this coronary artery calcium score. And then we validated this on over 20,000 individuals included in both asymptomatic and symptomatic individuals, including in several cohort studies and trials. So asymptomatic, we had the Framingham Heart Study, but then the second round of imaging, as well as the NLST, the National Lung Screening Trial. For symptomatic, we also evaluated the performance of the model in stable chest pain patients, where we had all-cause mortalities and outcome in specific, but also we looked at acute chest pain patients that had cardiac disease as well in a clinical trial. So the first we looked at deep learning and inter-reader, expert reader agreement. So we compared our automatic deep learning score to expert readers, and over 5,500 individuals we had both measurements available in the independent test sets, and we found a very high concordance. So overall indicating that a very similar quantification was done by the deep learning algorithm compared to these expert readers. If you then look at the results, I think the most interesting for this audience is the results on the National Lung Screening Trial data. What you can see here is the risk stratification of the model, which was, again, fully automatically done in a CT scan. And what you can see here, so there's a very large high-risk group with almost 4,000 individuals are included into this risk group. And you can see that the survival is much worse than the very low-risk group, for example. So here you can see that this model has, and this quantification, this biomarker, has a lot of importance for identifying high-risk individuals for related to overall survival. And if you even compare this to the lung rats categories, so the lung rats categories which were based on the NLST results, you can see that the risk profiles of the high-risk groups are somewhat comparable, indicating that it is as important to look at the lungs to see if the lung nodules than it is to look at the heart if there's coronary calcium on lung screening low-dose CT scans. What is also interesting is that this is also, for me, an example how deep learning can be used as an accelerator of science, because we could analyze these 15,000 individuals in these CT scans only in days on a cluster, so very fast. If we would probably require a whole army of radiologists to do this within a reasonable amount of time, and now with deep learning we can all do this very automatically with a very in only a couple of hours. So that is how I see deep learning really as an accelerator of science.
So now I want to show you a study that is related to this, and a specific related to body composition on CT scans. So here are 4 example lung cancer patients where you can see that they have large variations for fat, which is green and yellow, as well as muscle, which is red. So there's large differences of patients in these body composition measures. And now we want to use deep learning to quantify this automatically. So the deep learning methods, which you can see on the left, first localizes the L3 in the scan, and then does on the middle slice does automatically segmentation for the different body compartments. And what you can see on the right is also again an example of 2 patients that have the same BMI, so 25, but have very large differences in fat and muscle mass. We wanted to see, can we use this information now for lung cancer patients? So how did we did this? So we had a whole training phase for the deep learning model, where we used over 1,000 patients for training, which was done in a MGH and Brigham cohort, where we had as outputs muscle as well as fat and SAT measures for fat. So what we then did is we applied it to 12,000 individuals for a general outpatient population, and we wanted to see what is normal, right? Like what are the normalized values for patients that come to Mass General Brigham in Boston. So based on the distributions for age, sex, and race in these 12,000 individuals, we can then normalize our lung cancer patients for these. So we applied these values to 2 cohorts, the Boston Lung Cancer Cohort study of over 437 patients, as well as a TRACER-X study from Charlie Swanton of the Crick Institute in London that was almost 400 patients. And these are all surgical patients with lung cancer. So the first result is that we wanted to see
does smoking predict for lower body composition values? And indeed, we saw that for both fat measures, the smokers had lower values, significantly lower values compared to never smokers, as well as for muscle. So the smokers had less muscle mass than the never smokers. But also, if you wanted to look at survival, these are the survival curves in the TRACER-X for lung cancer specific survival for the extreme 5%. So looking at the patients who lost the most of fat, as well as fat, as well as muscle. And you saw that there was a significant stratification for survival for both the fat measures, but it was not for the muscle, for muscle depletion. And also similar to this, if we look at fat and SAT and muscle in the Boston lung cancer cohort study for overall survival, we found that indeed fat and SAT measures led to a worse survival, depletion of these, and for muscle and mass it matters less. So this really demonstrated that for outcomes, fat is more important than muscle.
So next, I want to give you some examples about representative CT images of lung cancer patients. So what you can see here is 6 different lung cancer tumors, and you can really see that tumors are different, right? They're not all round homogeneous, but some are, but a lot of them have much other characteristics, like spikiness or infiltrated into the surrounding tissue, as well as a larger heterogeneity of the internal tumor structure. So there's a lot of differences on a CT scan that we can see, that are quantified. But remember, in the clinical practice, only a maximum diameter is being quantified, right? So we simply say this tumor is 5 or 6 centimeters long. All of that other radiographic information is not being used. So AI, of course, is in a very unique position that it can really quantify that information automatically and extract much more data from the tumor phenotype in an automatic manner. So this is a study that we published in PLOS Medicine about 2 years ago, where we use the deep learning method to really quantify, extract information from a tumor lesion and try to see, can we predict overall survival of this? So only using the tumor, is this patient going to live or die in 2 years? So we quantify some traits of the tumor aggressiveness. So for this, we used several data sets for training and validation, because that is always a problem in deep learning, that we need enough data for training, which are illustrated here. And we developed specific models that could be used in the radiotherapy cohort as well as in the surgical cohort for stratification. And looking at the results in the Kaplan-Meier survival analysis, we found very nice stratification in these health out data sets of individuals into different risk groups. The biomarker, the deep learning biomarker, seems to be working both in radiotherapy as well as surgical cohorts. Similarly, these are the AUCs for performance. So there's a different way of showing the same results. And the only thing I want to show here is that we saw that these deep learning models were significantly outperforming a lot of the other models, including volume, maximum diameter, these imaging measures. Also, when we compare it to clinical models, we also saw a significant increase in performance for the deep learning models. And then if we would go to the imaging annotations, so we can look at activation maps. So where is the deep learning model looking to make this important assessment of, is this patient going to live or die in 2 years? And we've really found that the deep learning model was looking inside as well as outside of the tumor area. So really, this gives us the at least an indication that characteristics in the tumor rim are very important for prognostication. All right, so another application is using these imaging AI biomarkers to predict immunotherapy response. So this is a study that we did where we tried in 203 patients with advanced melanoma and non-small cell lung cancer. We said, are these lesions going to be responding to immunotherapy or not? So we quantified all the lesions that were available before start of treatment, and we looked 2 months into treatment, how did they respond to treatment or not, and can we predict this using the baseline scan only? And both on a lesion level, we found very significant performance for this imaging model, where we were able to significantly predict response of a specific lesion to immunotherapy. And we did much better than simply looking at volume, which is a measure that's often used in this regard. But also, if you look at a patient level, so by looking at all the lesions combined, we also found a nice significant prediction performance for these AI models, both for non-small cell lung cancer as well as the melanoma patients, really demonstrating that there's usability. So this could be a very important additional biomarker that could be useful to select before treatment if a patient would actually even have a benefit for IO, as well as during treatment. We potentially could also use these techniques to optimize and say, is it really working? Should we continue or not with the IO treatment?
So I want to conclude with one take-home message. So in this editorial that was published in Science in 2018, nicely demonstrated that there is an enormous reproducibility crisis in AI. So they investigated 400 papers and they found that only a very small percentage of them were actually sharing codes. Slightly more was sharing test data, and luckily more than half shared pseudocode, which means that they had a method description that allows you to more or less have an idea what they did in the study. But we also see that this really is a very big crisis. So methods are not reproducible, people do not share methods, they share any codes, and this is really a big problem. And I think there's a lot of other fields, such as bioinformatics, that we can really learn a lot from. So we wrote also a paper about this, transparency, reproducibility in AI, that we published in Nature a couple of months ago, where we really said, there's fundamental problems in the field, which also will even increase this AI winter notion. That we need to address. And there's a lot of different ways how we can address this. And we can learn a lot from other fields like biostatistics and bioinformatics, how we should share fully reproducible pipelines, how we should share data, the original raw data as well as the normalized data. So we can allow other investigators to very quickly check what we are doing and make sure it's right. So one of the initiatives that we are involved in that I want to mention briefly here is Model Hub, modelhub.ai. And this is a platform for a plug and predict solution for reproducible AI research, where you more or less have a standardized container, so environment, where you can put your AI model in and then use this to share this to the community. And then for others, it will be very easy to get these containers running locally on their own computers, or even on clusters, or even in the cloud. So I won't bore you too much with the technical details, but there is a lot of different ways how we can use this and how you can flexibly share these models. There's also other ways in the field how you can do this. On TensorFlow and TensorHub, for example, you can share models. But I think we should really, as a field, come together to better define these standards and make sure that we leverage the full potential of AI for medicine in this. All right, that was it. And I want to thank the following institutions and funding agencies. Thank you.
Hello, my name is Hayit Greenspan, and I'll be talking about AI in medical imaging, our initial steps towards supporting detection and monitoring of disease. I'm a professor of biomedical engineering, heading the medical image processing lab at Tel Aviv University, and currently on sabbatical and leave at the Department of Biomedical Engineering and Imaging at Icahn School of Medicine, Mount Sinai in New York City. I'm also a co-founder and chief scientist of Radiologics. It's a startup company that utilizes AI for radiology. So we have a lot of promise in this field, and by now we are doing pretty well in detection, segmentation, quantification, categorization, and we even see success of companies on the business level in bringing some of these tools into the clinic, but it's only just beginning. So in the past couple of years, we see twice the amount of FDA approvals than previously, and some in the radiology field. And we also see a prediction of revenues coming into the medical imaging AI market by 2025. Still, it is a very, very slow process, and we have a long way to go. And the reason is that we have many challenges. The main challenge is the data challenge. Collecting the medical imagery is very difficult. Labeling it takes time and expertise. We have, of course, ownership, privacy issues, etc. So while in computer vision, we have millions of images in systems such as ImageNet that can be used to label imagery, in the medical field, we have much less. And as we go to specific pathologies like a specific liver lesion, the numbers reduce even more. Not only do we have data challenge, we also have found out recently that we have modeling challenges. And that means that we see robustness issues. We have issues in taking a system that was trained in one location and making it adapt to the next site or to a different population. So these are generalization issues, robustness issues that we still need to address. We also would like more explainability in our systems. And just to note that our really focus area coming up is how we combine the image with additional data. So overall, we have challenges in training our networks with limited amount of data, and we want to build strong and robust systems. So just a couple of words on networks. I'm sure most of you are familiar, but to cover those who may be looking at this for the first time, our basic computational unit is this neuron here that has many inputs and nonlinearity in the outputs. And then when we say networks, we're talking about an architecture that combines many such computational units or neurons. These combinations are using weights, which are these arrows that you see here. And we have many different architectures that we can use. And the parameters, the free parameters are these weights that combine, that connect the different neurons. And these are the parameters that need to be learned. So these systems, for example, here, this one that was initially introduced in 2012 and won the ImageNet challenge. We see here many, many parameters between all these different layers of computational units. In this case, we have 650,000 neurons leading to 60 million parameters. Again, these are the parameters that need to be learned, and we learn in these systems by giving examples. So we have many images as input and many labels as output, and the system looks at these and trains by example. Here you see many, many such architectures or different variety of architectures that have come up over the years. So this was the original one in 2012. We have many more, and here the unit is the classical state-of-the-art networks for segmentation. A little bit of a historical perspective, in 2015, we were still asking the question if these networks can accommodate our medical tasks. And the reason for this question was that we don't have these millions of examples, labeled examples. But already in 2016, I co-led with my colleagues a special issue in IEEE TMI on deep learning in medical imaging, where we introduced research coming from all over the world, showing us that in fact we can use deep learning in the medical imaging space. In 2017, I co-edited the first book in this topic. Currently, we're working on the second version. And of course, we all know that by now, this field is really going very strong. So how do we solve our challenges? I'd like to start by talking about two of the main techniques involved in solving this and helping us go forward. I'd then like to show you a bit of our experience in the last couple of years in how we can develop rapidly some solutions, for example, for our new pathology, COVID-19. And finally, I'd like to conclude with where I am most excited these days in combining the images with additional clinical parameters to represent a patient versus just the patient image. So let's start with some of our solutions and our technology. Transfer learning. So in 2015, as we were trying to explore the option of using deep learning and these networks in the image space, we decided to use an existing network, input our own X-ray image to it, and see if it can represent it sufficiently so that we can extract a strong enough representation, which we can then use for categorizing into the different possible pathologies. And to our surprise, we could in fact take the network that was trained on clocks and animals and any kind of natural imagery and transfer the model that was learned and use it for our totally different task. So we were getting very strong results in categorizing and finding and detecting pathologies in the X-ray. In 2018, NIH started to open up some data for use. In this case, it was hundreds of thousands of X-ray imagery with 14 different pathologies. Now that we have the data that's more medical focused, we could fine-tune the networks. That means we transferred the model from the ImageNet, the classical imagery. We then showed it some examples, continuing to train the network and tune the parameters to our X-ray domain. And you see that our results are very strong. And we also started to localize the network outputs so that we can, in effect, explain what the network was looking at and see that we can actually find and locate the pathologies within the imagery. In 2019, we started continue to explore this transfer learning option. And the question was, what happens when we have a new task in hand? And this task is coming in with very limited data. So one thing we could do, we could take this ImageNet pre-trained model, show it some examples from TB in this case, and try to fine-tune it on this limited data set that we do have. Another option is to take the ImageNet pre-trained network, continue to train it, fine-tune it to all these 14 X-ray categories that we had from NIH. And now that the network is more tuned to X-ray, now go and show it a few examples from the TB and see if that network generalized better for our new task. So as you'd expect, we did see an improvement as the network was trained more and more in the domain of interest. Here you see two very small data sets from totally different locations, one from China, one from Canada. You see that as we were continuing to train with this NIH 14 categories, the results were becoming stronger. And even more interesting is that we could see more robustness in the solution. So when we went from one data set to another, we kept very strong results, whereas in the ImageNet pre-training, the results deteriorated very fast. We are continuing to explore this even further. So Nimrod in my lab very recently was looking at segmentation tasks, meaning we take an image and we output also an image, but this output image shows only the organ of interest or a lesion within it, in this case, the liver. For segmentation, as I mentioned, we have the unit architecture to support us. And the unit has a first part, which is like an encoding to represent the input image, and then more or less a decoding part where it extends back up to provide the same size output and give us the segmentation map of interest. It again learns by example. We show it many cases of inputs and outputs that we like. So the question was, could we use open data sets that are now coming to be more and more available in the medical field, where these open data sets are from different modalities and have totally different segmentation tasks, pre-train the networks, and then see an advantage when we show a new task with that, in this case, segmenting a COVID CT image, and this task we've never seen before, and we have very limited data for. So again, we have different tasks segmenting the liver, the pancreas, the spleen, the prostate, etc., the brain. Each one has a set of imagery and output maps. The network is trained on all of them. And this part of the network is basically being trained on all the different tasks. So this is the part of the network that we are continuing to use as we go to a new task. And now we fine-tune the entire network for this new task of the COVID. And as you see here in the results, we see better and better, stronger and stronger results as we go to this solution that we just proposed, the green being the true positives. So we're getting much cleaner segmentation maps, and we see overall an 11% increase in our performance. Finally, I'd like to share with you very recent work on transfer learning from a different perspective. These days, there are certain groups, one from Stanford I'm aware of, and also an effort being done in Mount Sinai, where the idea is to take an equivalent of the ImageNet data set and form what we call a RAD ImageNet data set. In this case, we're collecting a lot of imagery coming from different modalities, different anatomies, different categories. So overall, more than 1 million annotated radiologic images. And the investigation is to see if we can train networks with all of these images and use these pre-trained networks now to accommodate new tasks. What you see here are 3 different tasks that the network has not seen before on thyroid ultrasound, breast ultrasound, some knee MRI, and many more tasks were experimented with. And we see that networks that were trained using this pre-training of the RAD ImageNet were higher value results and more robust overall. So this is some of the work being done in transfer learning. We have much more going on, such as regularization issues that we put in our loss functions and more. But I'd like to shift now to a second large effort area in this space, which is data augmentation. So if transfer learning was to use an existing model and transfer its parameters to a new task, in data augmentation, we're trying to solve the data problem by generating synthetic data. We don't have enough data, so let's generate some data. So in one of the areas that we've been focusing on for many years, which is CT of the liver, we were able to, we built solutions and published on how we can detect the liver automatically. We can detect lesions within the liver automatically. And you see here some very nice solutions. And then we came to the question of, okay, let's categorize these lesions. Let's find out what category they are, if they're benign or malignant. You see that we had a very limited data set for this task. And so the idea came that we should augment this data set. Now, there are classical ways to augment a data set, and these classical ways are to take one image and make many out of it by rotating, shifting, translating, etc. And when we augmented our data in this classical way, we got an overall result of classification accuracy of 78%. At that time, generative adversarial networks started to come around, called GANs. And we were one of the first groups that started to use these to generate synthetic data, medical data. What you're seeing here are synthesized lesions from the different categories. So all of this is synthetic data. Now, first thing we wanted to know if the synthetic data is something we could use, if it looks like real data, and we explored this with 2 experts. And we saw that the ability to categorize the synthetic data was very similar to the categorization of the real data. And we also saw that they could not differentiate between synthetic data and real data. So this data really looked like liver lesions. Moreover, when we combined this data with the data that we had initially, we saw an increase in performance of the network by 7%. This work from 2018 has close to 1,000 citations. It is one of the first works in synthetic medical imagery that actually shows improved performance. Something new, very recent, that we are publishing now is the use of what we call StyleGAN for data augmentation. StyleGAN is one of the more recent NVIDIA proposed generator architectures. It's quite complex, as you see here. Again, the idea is to shift the representation to some kind of an encoding which represents the image very, very well. In this case, it represents the image in a way that we can actually focus on different features within the image. So what you see here on the left are all synthesized faces. And as we know, in these synthesized faces, some of them appear with glasses, then without, hair color changes, all these different things. And all of these are things that they can play with using this encoded vector W. So we took this architecture, which was trained for faces, in fact, and showed it a few cases of CT, and all of what you see here are newly generated CT slices. So this is totally synthetic data you're seeing here on the right. Now, as I mentioned, this vector W is very unique, and we actually used a new encoder that we included within the StyleGuide architecture to extract this vector from a given image. So that what we can do is, given an image, using this W vector, we can then play with the features of this image. So similar to putting and removing glasses, here we can augment the pathology, in this case, COVID, becoming more and more pathological, or reduce the pathology within the lungs going to the left. So we can play and generate a large variety of synthetic data for our use. And one of the use cases that we also see now for this representation W is that it brings us to a space where if you give me a training set that comes from a new site, I can represent each one of the images in this training set with this vector W in 2D space. I can then look for a number of the furthest points within this space. So if I have 50 points, I'll give you the 50 points that are most spread out in the space. And if we only have 20 or 10, I'll give you the points that are most far apart for this point sampling. And what we can use this for is to tell you which images you need to label. And only these images you'll basically use for the training of our network. So by using only 10 images, we can reach very strong results, and these are much stronger results than before. And so again, with these new encoding schemes, we can generate synthetic data. We can also use these encoding schemes to help us annotate smartly the existing data sets that we have. And our goal, again, is to reduce the load on our experts and to reduce the amount of data that we need. Let me now shift to an interesting experience we've had with AI technologies and the technologies and techniques that I've shown you so far in the new pandemic that has come to the world in the past couple of years. So what was very interesting for us is that when this pandemic arrived, we experienced the ability to develop very rapid AI solutions. And this is the title of the first paper that came out, Rapid AI Development, that already came out in March of 20. So we saw initial cases in late January, early February, and we in March already had a publication out. This publication is joint work of Redlogics with several academic institutions, including Mount Sinai, University of Maryland, and more. And what we saw is that we could use a lot of tool sets that we already had in 2D and in 3D, and very fast, build a robust system that can extract, as you see here on the right, the pathologies of interest. So very, very much along, in tune with the radiologists who were in February just starting to publish what you should look for and what the disease manifests itself as, which are these ground glass opacities in the periphery of the lungs. We were able to extract those pathologies with these AI tools. And what helped us was using all these pre-trained networks, using some augmentation schemes to extract, for example, the very exact segmentation of the lungs. Then we could extract the opacities within the lungs, and the combination of these two could give us a score for how much opacity burden was as part, which is the percent of the volume that was occupied by these opacities. And with these measures that we extracted automatically, we could actually compare between patients and track the course of disease of a patient over time. Moreover, we could continue and segment even finer lobe segmentation. We could extract many, many features that represent the opacities, the textures, shapes, locations, etc. And with these large set of features, we could also categorize into COVID versus other abnormalities such as pneumonia. And all of these tools are now being shifted to general lung abnormalities such as pneumonia versus ILD and many more chest diseases that we are now exploring. And another interesting fact of these past couple of years was that we wanted to see if these tools that we developed could really make an impact in the clinics. So most of the Western world decided not to use imaging as part of the diagnostic process. But in China and in Russia, and also in the Netherlands, CT was actually an active part of the diagnosis. What you're seeing here is one of the people in Moscow that leads a center that includes 130 different reading centers and different hospitals. And these AI tools that I showed you were introduced to the center, and he could actually see as he was sitting down before reading the case, he could get a report indicating a lot of the characteristics for each lobe. He could get an image that shows segmentation into the different categories, or track the percent of this manifestation over time. And all of this was available to the radiologist in reading the case. In a publication that came out in ECR in 2021, which was conducted by this group in Moscow, they introduced results of a large study that they did. This study covers 130 hospitals, 570 radiologists, and 36,000 cases that were read. And in this study, they were trying to see the capability or the performance with AI versus performance without AI. The overall conclusions were that accuracy was not changed. The report turnaround time was increased or basically reduced by 30%. So we were saving a substantial amount of time for the radiologist in making the decisions while keeping the decisions accurate as desired. Finally, in the next couple of minutes that we have, I'd like to tell you where we're heading. So far we've been focusing on analyzing an image or an image over time. But really, if we want to support diagnosis going forward, we'd like to develop the ability to combine image with clinical parameters. So we want to develop predictive modeling that uses more data than just the image. In a very recent work that we just published in ISB of 22, we went to explore particular focus area, which was mortality prediction for patients who are diagnosed with PE, pulmonary embolism. In this case, we have the image data as well as clinical data, and we fuse it together to get our solution. So we have imagery, we have clinical, we need networks to analyze both of them, and then we need to build a fusion mechanism for both of them together. We used or experimented with several networks. This network, SANet, is something we developed in earlier work to look at the CTPA imagery and make a prediction. These networks, XGBoost and TabNet, could work on the clinical data. We explored a lot of different fusion possibilities, what we call early fusion, late fusion, and intermediate fusion, which all refer to when we combine and fuse this information. And we found that the intermediate one was the best. And with this, we came to our final results, which you see here. We see that the multimodal solution overall outperformed everything else. In fact, it achieved more or close to 14% improvement than if we just did the imaging alone. Okay, it achieved more than 9% improvement from the clinical data. That means the imaging did add substantially to just the clinical data. But I think the most interesting result here is that we achieved 17% more accuracy in predicting mortality than the current state-of-the-art wool-based clinical wools that are used and are accepted in the clinics today. So definitely this shows that AI is going to make a difference in supporting actual decision-making, understanding of the patient situation, the severity of the disease, and hopefully supporting patient treatment. We have many challenges ahead. How to share information, so we're looking at federated learning. How to make our systems more robust, so we're looking at adaptation of the networks over different systems and populations. And all of this is coming up in our current and future works. I'd like to thank you very much for your attention.
Dear friends, thank you for the invitation to this presentation. I'm Haotian Lin, Professor of Ophthalmology from Zhongshan Ophthalmic Center, Xunying University, Guangzhou, China. Today's my topic is artificial intelligence in ophthalmology, a window into systemic disease. Ophthalmology is a pioneer in the field of medical artificial intelligence. We know that the rocket development of AI could mainly be attributed to the development of computing power and the growing amount of data. Where we can thank the computer scientists for the former, we as ophthalmologists should be aware of the latter. The eye is informative and accessible due to its inherent anatomical features. As an organ located on the body surface, most examinations can be done non-intrusively. Furthermore, the eye structure is complex and compact, containing various cells and tissues, which could produce multi-modal data through diverse examination methods. These features give us easily collectible metadata of good quality and quantity, making the eye a prime candidate for medical AI. Our team has archived a few results in the field of ophthalmic AI. In the terms of disease diagnosis, we first developed a diagnostic model for congenital cataracts, which we named CC-Closure, and built a corresponding multi-hospital platform for disease management. Then, aiming at visual impairment screening in infants, we developed a model based on video datasets and successfully identified the behavioral dynamics of visually impaired children. We also developed a screening and grading model for retinal detachment based on wide-field fundus images. Finally, our team originated the Vision workflow to develop dense annotation based on anatomical and pathological segmentations, presenting a brand new method to handle ocular image data. A good doctor must keep an eye on the longitudinal development of disease. Therefore, we have a serious work regarding disease development, starting from a high myopia prediction model for children. We also developed a model to predict the post-surgical complications of congenital cataracts and merge it into a synthesized service platform for disease follow-up. Also, we identify serious risk factors to predict the onset of congenital cataracts and achieve satisfying results. Furthermore, artificial intelligence can be applied in healthcare management to assort medical resources better. For example, our team developed a collaborative management system for cataract patients, covering diagnosis, referral suggestions, and follow-up sections. On the other hand, we analyzed the characteristics of the Zhongshan Ophthalmic Center virtual hospital during the COVID-19 pandemic. Our results prove that the effectiveness of internet medical service and providing information for further improvement and development of such AI hospital during the pandemic. Our work would only be a glimpse into the total capacity of ophthalmic AI. The most significant advantages of ocular anatomical structures is that it provides a window for observing neural and vascular structures in vivo, making it possible to intuitively record and study physiological and pathological changes, while not many other organs provide such a chance. Researchers have found that the eye could indeed be beneficial in hinting at the systemic health condition. Examples are too many to count. Besides the familiar ones such as diabetes and hypertension, characteristic ocular changes could indicate many other diseases originating from various systems. For example, head trauma could present as occlusive microvasculopathy and anemia as a pale disc. With the help of ever-developing AI technology, will it be possible for us to trail systemic disease through some specific ocular symptoms? Previous works have proven a positive answer. For example, conditions such as cardiovascular disease, chronic kidney disease, and Alzheimer's can be identified by ocular changes. Furthermore, one can use fundus image to obtain biomarkers such as sex and age, revealing the abundant information concealed in ocular data that were yet to be discovered. In the search for what we can dig from ocular data, the disease of the hepatobiliary system caught our attention. Hepatobiliary illness affected a large proportion of China's population, causing severe public health problems. The liver is the metabolic center of the body and is responsible for multiple body functions. Therefore, its malfunction could cause a series of multisystemic symptoms, including ocular ones. Previous studies discovered changes such as KF rings and cherry red spots, but the most typical and common symptoms is undoubtedly sclerosis, also known as jaundice and yellowing of the eye. However, these symptoms have relative low specificity and sensitivity when identifying hepatobiliary disease. Take jaundice as an example. Several other conditions could cause the yellowing of the eye, and it also requires the serum bilirubin to reach a certain level before coming into sight. As a result, ocular symptoms alone are currently of limited applications in clinical scenarios, considering the diagnosis of liver disease. Determined to discover the underlying link between ocular presentation and hepatobiliary disease, we will screening and diagnosis of AI models based on eye images. We obtained the liver examination results alongside the slit lamp and fundus photos as model inputs. Based on this data, we built a screening model for hepatobiliary disease, and the AUC reached 0.74 and 0.68 respectively. Additionally, we identified the 6 categories of common hepatobiliary disease and built individual diagnostic models. In particular, the liver cancer model and the cirrhosis model achieved relative satisfying results, proving that analysis of ocular images, slow AI technology could assist in the screening and diagnosis of hepatobiliary disease. Furthermore, we compare the model's performance with ophthalmologists and hepatobiliary surgeons, respectively. The results indicate that our models achieve higher accuracy than doctors based on both slit lamp and fundus images. These results imply that AI model could uncover traces between hepatobiliary disease and the eye that are hard to discover by human eyes, and perform classification tasks better than human experts. To further explain the model, we conducted visualization experiments to unveil the AI black box. Slow salience maps, occlusion tests, and grayscale tests, we discovered that the conjunctival and scalar iris color of optic disc area and fundus vessels mainly contribute to the diagnostic decisions of the model. This result is consistent with the anatomical structure of the eye, suggesting that our models are explainable and reliable. It also uncovers a possible direction for future studies on pathological connection between the eye and the liver. Our results was published in the Lancet Digital Health, and we are honored to have the homepage recommendation. AI models should not remain as serious. Therefore, we launched the models on Zhongshan Ophthalmic Center AI healthcare platform to put them into practice. Users can upload their slit lamp and fundus images to get the diagnosis suggestions on hepatobiliary disease. This is our first step in implementing the AI models in the real world. To maximize the effect of the models, our next step would be to implement them in the hierarchical medical system. For example, the screen models could be installed in primary care scenarios to provide the general public with basic risk specifications. On the other hand, the diagnostic models could be installed in the tertiary hospitals for triage service. The model can also assist the specialists on virtual hospital platforms to help better integrate medical resources. This project will go through further improvements to reach its most refined form. Our future steps include the real-world validation of the AI models to improve the robustness and test the performance in the general population. Also, we plan to develop a corresponding mobile app to explain the application scenarios of our models. Finally, as previous work implied, other systemic diseases presenting specific ocular symptoms are also worth further investigations. Our ultimate goal is to explore the underlying connections between the eye and other systemic disease. Furthermore, we hope to develop an ocular-based AI health management system that will provide a new aspect for future healthcare service. This is all for the presentation today. Thank you for your time and attention. See you next time.
Hello, everyone. I'd like to thank Cell Press for inviting me to share with you our research progress on application of AI technologies to healthcare and medicine. There are major challenges in applying AI in medicine. This includes data challenges. As you know, data present in alien and lots of modalities. They're difficult to combine. Often they're unstructured, unlabeled, making them very difficult to be inputted into machine learning and AI models. There are also technological challenges. Integration of immense clinical and high-throughput biology data. Multitask learning on disease diagnosis and therapy and outcome predictions are still very challenging. Lastly, cost-effective computation capabilities still need to be built. As all of you know, recently, electronic medical records information are in rapid growth. And there are diversity of digital health data, such as imaging data, electronic medical records, as well as diagnostic value data. One of the major advantage or potential for AI in medicine is to realize its enabling ability for uneven resource distributions in healthcare. Several years ago, we wrote an article in Nature Medicine outlining implementation and application of AI in medicine. Here, we divided applications in several areas. The first one, which is currently ongoing, are diagnostic areas. And it is integration of such as technology such as computer vision or multi-omics into clinical as well as decision-making processes. The area of increasingly applied is therapeutic areas such as therapeutic outcome predictions. Lastly, population health management, meaning taking patients in the early stage of disease or even the health aid management, apply AI and big data for disease outcome prevention and predictions, as well as supply data to administrations as well as government for better distribution and usage of healthcare resources are all areas of interest. The health information, mainly patients' medical data, are stored in different places, mainly in hospitals. And current way of utilization of patient data is not optimal because there were silos and also there are barriers of sharing the data in a confidential and fair way. Those also need to be addressed. I would like to use some examples how we apply AI technology for diagnostic of diseases. My first two examples are diagnosing eye diseases. In the first application of transfer learning in healthcare and medicine, we studied using AI for diagnosis of common retinal diseases, such as wet macular degeneration or choroidal neovascularization or CMV, diabetic macular edema, which is a most common complication of diabetes, drusen, which is early signs of macular degeneration. In this case, we used a well-known AI technology called transfer learning to enabling the neural networks to learn and train and predict outcomes. We trained the AI first from tens of thousands of images from ImageNet, and then use this network to recognize the eye disease images, such as listed here. We further train the network after prediction precisely eye diseases to predict the disease outcomes for the pneumonia, pediatric pneumonia. In this case, childhood pneumonia, bacterial versus viral pneumonia. Specifically, instead of using millions of images for training an accurate AI system, we used a fraction of images, in this case, about 200,000 OCT images, and with a fraction of them labeled with physicians, and then train the AI system with 100,000 images, validated the datasets with 1,000 images. This is the result. The AI system achieved very high accuracy for urgent review of blinding retinal diseases, such as diabetic macular edema and wet macular degeneration. The AUC is more than 95%. In addition, we compared the AI ability of diagnosing this disease with retina physicians in the United States. What we found here is that the AI can achieve at least mid to senior level retinal specialist ability for diagnosing diseases. I want to bring your attention to the fact that the AI was only trained for 200,000 OCT images. I'm pretty sure that if we give AI 1 million or several million images, it should be able to recognize and accurately predict in more than 99% accuracy for those conditions. One of the challenges of applying AI in medicine is AI's explainability, often called a black box phenomena, in that the AI often will tell you the result of a prediction, however, will not be able to give physician or patient why the AI thinks that way. To address this question, we, in this paper, apply a technology called exclusion map, where we systematically blocked a part of the image and ask the question, which part of the image, when we block, will degrade the accuracy of the prediction. Then we label this area with a heat map. As you can see here on the panel A, that the heat map specifically labeled the lesion of the retina, indicating that AI is looking at the correct location or lesion of the disease. We'll also be able to use this to guide the treatment strategies. In this case, in the panel B for choroidal neovascularization or wet AMD, or C in diabetic macular edema. As you can see, the AI was able to identify the correct lesion and quantify the severity of the lesion and make a decision whether the patient needs to be treated again in the next visit or not. Again, here to show that after being trained in diagnosing the eye disease, then we further did transfer learning to train the AI on the pediatric chest X-ray for diagnosis of pneumonia. In this case, we only used 5,000 chest X-ray images, was able to provide 90% of the accuracy for diagnosis. Our next example is to use AI to detect systemic disease using retina images. You may know that retina is a neuronal tissue with rich vasculature that can be a window for systemic health. Therefore, using AI to diagnose eye disease, such as I alluded here, and done by other researchers for other eye diseases, is something that is not very surprising. However, we want to know whether we can use AI to diagnose some common systemic diseases. However, those diseases are not be able to discern by either ophthalmologist or by any specialist from the retinal images. What I try to say is that we are trying to use AI or using AI's ability to identify features that is not discernible by human eyes, but was able to extract by the AI to provide diagnosis. In this paper, what we was trying to do is to train the AI systems to diagnose systemic disease such as chronic kidney disease and type 2 diabetes solely from retinal images. We trained the AI system from 110,000 retina images from 57,000 patients. And here's our systems of trying to do this. We also correlate the clinical symptoms and metadata with the retinal images. Finally, to make sure that this can be widely applicable, we develop iPhone-based system where we can capture those retinal images using smartphone and diagnose right away those conditions at the point of care in a prospective study. Showing here is the AI can achieve very high accuracy in diagnosing chronic kidney disease and type 2 diabetes. Those are different data sets, including external and internal data sets or prospective studies. They all achieved anywhere from 0.93 or to the 8.5 AUCs. We want to explain why AI can discern chronic renal disease. One of the key features of renal disease diagnosis is based upon the estimated glomerular filtration rate, or eGFR. It is the single most important measurement for renal function. What we have done here is to do a regression analysis using fundus images and the value of the eGFR. What we show here that the eGFR can be estimated using the retina images with an R-square of 0.5. Similarly, we'll also be able to estimate the glucose level from retinal images. That all partially explain why the retinal images can discern type 2 diabetes. Finally, what we asked the AI to do is to predict the onset over the longitudinal course when a patient will develop or have high risk of developing either kidney disease or type 2 diabetes. Again, the AI was able to achieve high accuracy in predicting who's going to be diagnosed with either kidney disease or type 2 diabetes in the future. This is, I consider to be amazing because as a human physician, we have no way of knowing which patient will be able to diagnose with the condition in the future. And AI provided this unprecedented opportunity for us to intervene and hopefully dramatically reduce the disease burden for these two very common conditions. My next two examples of AI application or computer vision application in medicine involving diagnosed COVID-19 pneumonia. During the pandemic, we feel there's urgent need to develop quick and accurate diagnostic tools for computerized tomography or chest x-rays. Therefore, in this paper, we describe our effort in using 6,000 patients and more than 500,000 CT images to develop a system for diagnosing pneumonia. In this case, this system not only were able to segment specific lesions such as ground glass appearance or consolidation lesions or fibrosis or other lesions. It can also predict outcome of critical illness progression, as well as correlate with clinical features or clinical laboratory data. In this case, the AI system also achieved very high accuracy with average AUC of 0.98 and with a external validation datasets also achieve very high accuracy. In addition, to the right side, what we're showing here is the AI can help the junior radiologist to achieve senior radiologist level with a choice of decision-making process. This is also very important, as for the emerging diseases, none of the medical community will have lots of knowledge in diagnosing those conditions. So the AI system such as this one will be very helpful in bringing up the capabilities of all level of professionals, healthcare professionals in diagnosing diseases, such as in this case, COVID-19 pneumonia. Next, we ask AI to stratify the risk factors and clinical prognosis for severe or critical illness in COVID-19. Shown here, the AI was able to identify many features now we know are important for the prognosis or progression of the disease into critical illness, such as admission to the ICU or put on the ventilation or death. This will allow the hospitals and the physicians to allocate medical resources to the neediest. In parallel of this system was able to deploy not only to the Wuhan frontline during the pandemic, and it was also be able to be deployed as a AI system globally, and that was published by the China National Center for Bioinformation, and was downloaded globally more than 3 million times, and contributed to the global comeback of this condition. We also in parallel developed a chest ray AI system to diagnosing COVID-19 pneumonia to help countries or areas where the CT is not available for diagnosing the disease. And again, this is actually an important tool. It was based upon 145,000 chest x-rays. Not only was able to diagnose pneumonia, such as COVID-19 pneumonia, it was able to also diagnose other conditions such as anaphylaxis, pneumothorax, or nodules in the lung, or TB. Therefore, it's a very valuable tool for common use in medical care. I want to bring back your attention to the convergence of multimodal and multi-omics data. The challenges are how to acquire and combine diverse clinical biomedical data, such as immense amount of the high throughput sequencing data and the electromedical records data, how to integrate all the information to predict disease information, disease diagnosis and outcomes, and how to use this to generate the biomarkers, therapeutic targets, phenotype-specific genes and interactions, or disease phenotypes. Here we have done some attempts to address such challenges. As we know, the medical records consist of images and the textual information, and how would we be able to actually combine those? We actually studied in this publication here. In this case, we first labeled 50,000 electromedical records in this case, pediatric disease records. From there, we're able to use natural language processing and deep learning to form AI system to extract 1.3 million raw pediatric medical records, making them fully structured database. From there, we proceed with disease diagnosis or classification. So this is the system we're trying to use and also to deploy. At the time, we did not tell the AI system how to make a decision or diagnosing a disease. However, as a physician, we often diagnose a disease by a process called hypothetical deductive reasoning, meaning we take patient's chief complaint, present illness, past illness of doing this project. We did not tell the AI system how to make a classification or diagnosis of pediatric disease. In contrast, physicians like ourselves diagnosing disease using a process called hypothetical deductive reasoning. In this process, we take patient history by record chief complaint, present illness, past illness, and past medical history with combination of diagnostic test. In this case, the AI, without actually being told what to do, followed precisely the process of hypothetical deductive reasoning by himself, meaning it determines the most likelihood of what organ or tissue system is being affected in this disease process, such as drawn in this slide here. The AI system was able to diagnose major classes and specific pediatric diseases with high accuracy, as shown here that the major disease categories, respiratory, GI, general systemic disease, neuropsychiatric, or genital urinary tract diseases. Moreover, the AI system performance is comparable to the mid to senior level pediatricians. Shown here in the second column are our AI systems average F score, which is higher than the mid-level physicians and comparable, just slightly inferior to the senior physicians. However, just like I said before, I want to remind everyone that we've been training the system with 1.3 million raw pediatric medical records. However, if we were giving the system 10 million medical records, I am certain that the AI system will be able to perform at the level of senior or if better than senior pediatric physicians. This article, when published, caught attention to worldwide media, one of which is New York Times. I think what I just been saying here is very revealing. So in this article, let me read some of the sentences which reflects the need using AI to assist physicians in the setting of rural diagnosis or emergency diagnostic scenarios. Each year, millions of Americans walk out of a doctor's office with a misdiagnosis. Physicians trying to systematic when identify diseases and illness, but bias creep in, alternatives are overlooked. Now, a group of the researchers in the United States and China has tested a potential remedy for all too human varieties artificial intelligence. So this is actually saying that the AI system, by being able to combine all the data, learning all of the medical knowledge and output a multitask system, should be able to predict outcomes and tell the physicians what to do and avoid medical errors and avoid overlooking some of the fatal mistakes that potentially can be caused. I have so far telling you about using the medical medical records data, but there's a huge amount of the data accumulating from the genomics, omics, or multi-omics side. I want to share with you some of our progress in using those data in diagnosing diseases. As all of you know that we had a genome revolution and starting with genome association studies. In this case, we're using macular degeneration as a test case. We're able to, along with international consortiums, be able to identify all the disease genes which predispose an individual to age-related macular degeneration, or AMD. When using all that information, stratify an individual patient's risk scores, we're able to determine at the start of this patient, or when the patient is born, what is the risk actually for this patient to develop lifelong risk of having macular degeneration. So in combination of HTR1, CFH or C3 plus environmental factors such as smoking, now individual patient homozygous for all three individual variants plus smoking will have extraordinarily high risk, about 5 to 1,000-fold increased risk of an individual compared to an individual who do not have risk variant or not smoking. So this really illustrates the power of genetic susceptibility and the genetic testing. I want to give you another example of application of AI in cancer diagnostics. As you know, cancer is complex and heterogeneous and is much unmet medical needs. Find biomarkers for accurate diagnosis of cancer or classification or predicting its prognosis or treatment response is of a major challenge. Obviously, another major challenge is find novel therapeutic drug targets. Therefore, we set out to identify and biomarkers by applying machine learning and big data using methylation DNA markers. In this study, we're able to show that DNA methylation markers are very accurate in diagnosis and prognosis of cancer. Here we use 4 very common cancers: breast, colon, lung, and the liver as an example. We're able to differentiate those cancer types in a multi-class testing with more than 95% of accuracy. In addition, we were able to identify metastatic lesions in any tissue, such as metastatic colon cancer to the lung, in using tissue biopsies, and predict the prognosis of treatment response. However, having tissue biopsy is not optimal. We move on to want that to use liquid biopsy than tissue biopsy for non-invasive cancer detections, because it has advantage of the following. Because cancer cells shed circulating tumor DNA into the blood, and the ctDNA can be detected by DNA methylation or mutations. Moreover, DNA methylation is more sensitive and specific than mutations for particular tissue cancer of origin. It is non-invasive. It represents a whole and dynamic cancer pictures, and it can perform real-time monitoring. So in this first large clinical study on DNA methylation and cancer liquid biopsy, we use the example of hepatocellular carcinoma or liver cancer as an example. Here, we first identified DNA methylation markers that can differentiate liver cancer from its surrounding tissue and also blood methylation patterns. Then we are using the markers to look at several scenarios. First one is cirrhosis versus hepatocellular carcinoma, normal versus cirrhosis, as well as normal versus hepatocellular carcinoma. In all cases, we're able to identify the DNA markers that can distinguish cancer from the benign liver disease or normal individuals from blood samples. Not only this, we were able to also determine the response of the therapeutics, meaning that before treatment, after treatment with response versus recurrence or progression of disease, the methylation marker has dynamic changes reflecting those pathological changes. Moreover, from the different staging of the tumor samples, we're able to show that the DNA marker can reflect that as well as progression of the disease. We also can use those individual markers to track individual disease and its response, such as in those cases individually, and predict prognostic values. This is in contrast with AFP, alpha fetoprotein, for which is a standard liver cancer diagnosis. However, it is notoriously insensitive for early cancer detection. We're able to raise the AUC from 0.8 to 0.96 in the liver cancer diagnosis as compared to AFP. So I have given you several examples how to integrate multidimensional big data together to diagnose disease and predict treatment outcomes and adverse effect. We're hoping that the AI can continue making transformative impact in disease diagnosis, longitudinal patient follow-up, outcome predictions, for which I thank you for your attention.
Hello everyone, my name is Baiying Lei. I'm from Shenzhen University. My talk today is multi-time, multi-modal neuroimage learning for brain disease diagnosis. According to 2000 Alzheimer's disease facts and figures, people living with dementia around the world has a global impact. Around the world, there will be one new case of dementia every second. And 50 million people worldwide are living with dementia in 2018. This number will more than triple to 150 million by 2050. The total estimated worldwide cost of dementia in 2018 is US $1 trillion. This figure will rise to US $2 trillion by 2030. Alzheimer's disease (AD) is the sixth leading cause of death in the United States. It has clinical impact of memory loss, cognitive impairment. The early stage of AD is mild cognitive impairment, which can be divided into early stage MCI, EMCI, or late stage MCI, LMCI. It also can be divided to sleep MCI, SMCI, or progress MCI, PMCI. With time by the stark difference between normal control MCI and AD. Longitudinal analysis of AD can monitor disease progress. With time goes by, the brain health of normal control MCI and Alzheimer's become downgraded. From this figure, we can show the difference between different stages of MCI and AD in different time points. To monitor the disease progress can delay AD progressive. It also has the challenge. For example, AD die within 3 to 10 years. MCI to AD has a conversion rate of 10% to 50% per year. The solution to this challenge is early diagnosis and early treatment, so that we can monitor disease progressing to prevent the disease. Multimodality, for example, MRI, PET, fMRI, DTI can provide the structure and the functional information. Multimodal data can provide comprehensive information. Machine learning can identify the well-known informative biomarkers accurately. However, it has the challenge of high feature dimension and small sample size. Therefore, we need to accurately identify the informative features to reduce the feature dimensions. The clinical score of AD include MSCE, ADAS-COG, CDR-SOLVE, and CDR-GLOBE. Multi-time samples are more sensitive to early pathologic changes, and also it can predict the disease progression. Deep learning can analyze the neuroimage features more effectively. However, for multi-time point data, they have the challenge of subject dropout and image quality issues. So we want to achieve more accurate early diagnosis by deep learning techniques. The traditional machine learning pipeline for neuroimage analysis include processing of the each other neuroimage and feature extraction, feature learning, and then for prediction or regression. The machine learning techniques include discriminative learning, relation localization, low-rank constraint, and spatial term constraint. However, the machine learning techniques need the complex processing procedures. Also, the feature extraction requires experience. By contrast, deep learning can analyze the data without process. Also, it doesn't need any experience. It can do prediction and regression in an end-to-end way. The typical deep learning techniques include graph convolution network and long short-term memory. Also, we validate our machine learning and deep learning technique on the public Elena and PPMI dataset. First, let me introduce the descriptive learning. It introduces geometric information by abstract juggling. It means that it introduces P, a non-negative matrix, and lambda matrix. We want to expand the class difference so that we can more discriminative to separate two classes. For relational localization, actually it uses the feature similarity, subject similarity, the feature and feature subject and subject relation based localization is just map the origin space to the target space so that we can easily to separate two classes. namely relation localization preserves the feature and feature, subject and subject similarity. Let's illustrate the feature and feature similarity and subject in this matrix. And also we can include the response matrix relation-based localization, and this figure shows the subject regression space and also clean score labels. This response matrix relation. This is the objection function for multiple relation localization. The first term is list score regression for data fitting. The second term is column-wise relation in response variables, and this term shows the row-wise relation in response variables, and this term gives us the feature and feature relation, and this term illustrates the subject and subject, and the last term is the sparse term for group sparse. And this shows the kernel for get the similarity and also the equation to calculate the similarity. Also, we introduce sparse low-rank learning. This is the sparse and low-rank localization objective function. RE norm can introduce sparsity, and the choice norm introduces the low rank. This is illustrate the low rank feature vector to be dependent. The ensemble Courier entropy and sparse term constraint can have the denoise. Courier entropy is robust for removing outliers, and field the small term can introduce the time constraint because we use multi-time point data. For the sparse constraint, we can introduce locality preserved projection, and this illustration the sparse constraint in the matrix space. Let me introduce the first application for AD. We introduce machine learning for multi-modal analysis. We developed a relation localized discriminative sparse learning for AD diagnosis. For multimodal MI, PET, and CF data, we utilize the feature and feature similarity and subject and subject for relational localization. Also, we introduce the geometric information by abstract juggling. Finally, we can use the relation localized discriminative list score regression learning for select the most informative features. From this experimental result, we can show that our relation localization and discriminative learning is quite effective in three classification tasks and for prediction tasks, which are proposed algorithm out from the traditional multitask and lasso and also list score based method. From this prediction result, we can show that the accuracy is quite high, which is quite useful for computer-aided analysis of And our method is validated in Italy based on 2004 subjects among 50 centers and among multiple institutes. Our accuracy of AD-YSNC reached 94.68% and PMC-SMC reaches 80.43%, which is higher than state-of-art method. Also, we proposed a self-covered brain network estimation and joint non-converse multitask learning for identification of early Alzheimer's disease. We use the self-calibration tool for the functional brain network construction, and we use the joint non-converse multitask learning to extract the most informative features for early AD diagnosis. And from this experimental result from 6 tasks, we can see that from the comparison of different feature selection method, the proposed method outperforms the traditional lasso and multitask and get the best result among 6 tasks. Also, in the accuracy in more classification tasks based on the network assessment by the Prof with different regularized parameters values in the interval can show that our method is not sensitive to the parameters. Our method can extract the top 10 most discriminative connection associate our algorithms which are useful to early Alzheimer's disease diagnosis. For multi-time point data, we proposed fused sparse network learning for longitudinal analysis of MCI. For different time point of RSF data, we use the phased sparse network to build the brain networks and extract the multi-time point features. We use the parameter-free centralized multitask learning to get the most discriminative features. Finally, we use the simulated network fusion to fuse different time point data. From the experimental result, we can identify the important brain function connective network at different times. Also, we achieved error MCI-YSNC accuracy of 87.23. For EMCI-YSNC, we also get accuracy higher than 80%, which means our proposed methods are quite effective. Also, from these figures, we can see the distribution of important regions for MCI and EMCI in the baseline and year 1 respectively. Also, we use the deep learning for multi-time analysis for AD diagnosis. We propose deep and joint learning of longitudinal data for AD prediction. For 6 time points data, MI data, we propose temporary constraint joint learning to select the most informative features, and we also use the deeper polynomial network encoding and ensemble subnetwork regression to predict the clinical. From the experimental result, the longitude with data filling and is better than that without data filling, and the imputation is quite effective for AD prediction. And this is the most discriminated ROS for the prediction of 4 types of clinical score, and all these discriminant ROS are quite effective for AD prediction. For early AD diagnosis, we use the deep learning techniques, that is graph convolution network. We propose a graph convolution network with similarity awareness and adaptive application for disease-induced deterioration prediction. For the similarity, we just use the similarity between normal control and patients, and also for the adaptive calculation, we just introduce the calibration mechanism to adjust the feature adaptive to get the better prediction result. From these figures, we can show that our proposed method have fitting effect on graph on descriptor of my features, and our method also can extract topostatic discriminative features in FMI and DTI brain connection networks. Also, we extend our AD method to PD. We use machine learning for multi-time analysis of PD. We propose the Parkinson disease classification and clinical score regulation based on united embedding and sparse learning from longitudinal data. This is the pipeline of our proposed method. And from the experiment in 3 classification tasks, we can see that our united embedding and sparse learning are quite effective for PD prediction and detection. Our method also outperforms the traditional PCA multitask learning and MSSL method. From these figures, we can show the importance of each brain regions in different time point and in different tasks. And also these discrete brain regions are quite effective for PD prediction and detection. Also, we applied the machine learning for both AD and PD. We proposed the adaptive sparse learning, use multi-template for neurodegenerative disease diagnosis, and we use different templates to extract features, and based on these extract features, we use the adaptive feature learning based on the adaptive sparse control and subspace learning. And we evaluate our method for 3 tasks, and from this task we can show that multi-template method is better than the single template method, and also our proposed adaptive sparse learning is better than other sparse learning method. And this is the top 3 RI for different classification tasks. From this, we can show that our proposed methods are quite effective for neurodegenerative disease diagnosis. Also, we extended the machine learning method for AS diagnosis. We proposed a self-weighted adaptive structured learning for ASD diagnosis by a multi-template, multi-sample representation. This is the multi-template based network and feature extraction. And for feature selection, we use self-weighted adapted structured learning. Finally, we use weighting for ASD diagnosis. From these figures, we can show that multi-template learning is better than single template learning, and our multi-template, multi-center representative get the best result. And also, we can try the most discriminant connection for ASD diagnosis. The final work is about the diagnosis of obsessive compulsive disorder with spatial similarity award learning and fills the deeper polynomial network. And for brain network construct, we use the spatial similarity award learning, and for the deep learning, we use the deeper polynomial network for OCD diagnosis. From this experiment result, we can get a very impressive OSD diagnosis result. And we can extract the top 20 different connective for NC with OCD and get quite impressive diagnosis result. The last is my conclusion. I introduced the multi-modal analysis and longitudinal analysis for brain disease diagnosis. We also introduced machine learning methods for such as descriptive sparse learning, relation localization, spatial constraint, and deep learning methods such as G-SHAN for brain disease diagnosis. Thank you, and that's all.